नाही नाही, करायचं असेल तर रेस्ट एव्हरीबडी इज ऑन म्यूट करू.
So a very warm good afternoon to each one of you. I am Dr. Suman Kulshrestha from IIP Digital Media team. Today we are very fortunate to have a wonderful panelists alongside us from IIP Telangana. And we have our resource person, Dr. Vaibhavi, who is already here. Very soon we would be starting the session. Before even taking forward, I would like to request Dr. Himani, who is the moderator today, to take the session forward.
Yeah, thank you, Dr. Suman, for the technical assistance.
Most
Good
welcome.
afternoon, everyone, participants, respected speaker, and team of IAPWC Telangana State. On behalf of Telangana State IAPWC, I, Dr. Himani Poddar, take this opportunity to extend the warm welcome to today's webinar, Pelvic Girdle Dysfunction, by Dr. Vaibhavi Harne. Before commencing the webinar, I would like to introduce my team that operates under the guidance of Dr. Ruchi Vashne, Treasurer IAPWC, Dr. Sanjeev Jha, President IAP, and Dr. Ramya, South Zonal Head. Our regional team includes Dr. Hena Rajshekhar, State Coordinator, Dr. VV Manjula Kumari, Joint Coordinator, Dr. Monima Billa, Sub-Coordinator, Dr. Hima Bindu, Sub-Coordinator, and myself, Dr. Himani Poddar, Sub-Coordinator. Now, without any further delay, I would request Dr. Manjula to introduce our speaker for today's webinar. Over to you, Manjula ma'am.
Thank you, Dr. Himani.
Yes.
On behalf of IAPWC Telangana team, this is Dr. VV Manjula Kumari, Joint Coordinator. I take the privilege of inviting Dr. Vaibhavi Harne. She's a beautiful soul and passionate physical therapist dealing with the pediatric as well as obstetrics and gynecology wings at Rainbow Hospitals, Hyderabad. She has completed her UG in physical therapy from Government Medical College, Nagpur, and PG from Seth GS Medical College and KEM Hospital, Mumbai, Maharashtra. She also holds years of physical therapy licenses in the states of Washington and Michigan. She's an expert in treating pediatric conditions like static encephalopathy, developmental delays, Erb's palsy, plagiocephaly, gait disorders, etc. Apart from pediatric physical therapy, ma'am also deals with obstetrics and gynecology also, in which she'll be treating back pain, pubic symphysis dysfunction, and pain management to women too. Ma'am did a great efforts in updating her knowledge through continuously attending her CMEs and other things. Her relentless contributions for the evidence-based practice are always admired by her patients. I take the pleasure of inviting you to this particular session, ma'am. We are eagerly waiting to listen from you. Before that, I request Hannah, ma'am, to extend her warm regards to you, ma'am. Thank you.
Thanks, Dr. Manjula. Good afternoon, one and all. On behalf of IAP and IAPWC Telangana, I extend a warm welcome to the speaker, Dr. Vaibhavi, my teammates, and all participants on this platform. Our greetings to Dr. Vaibhavi, senior pediatric physiotherapist of more than 20 years experience, for consenting to be the speaker for this webinar. I am sure, madam, your expertise will definitely benefit each of us. We wish you all the best for this session. Now I hand over the time to Dr. Vaibhavi so that we could learn from her in a good way.
Good afternoon, everybody. Can you hear me?
Yes.
Yes, we can hear you, madam.
Thank you, IAP WC Telangana State team and IAP team for giving good introduction. And I thank again for giving me this wonderful opportunity to conduct this webinar. As you guys know, I'm going to talk about pelvic girdle dysfunction. I work in OBGYN setting and pediatric setting at Rainbow Children's Hospital and Birthright by Rainbow. I see a lot of patients, especially the pregnant women, coming down with pelvic girdle pain, and being able to distinguish between pelvic girdle pain and low back pain has helped my patients with good results. Let's start the presentation now. Pelvic girdle dysfunction. Yeah. So what is pelvic girdle dysfunction? Pelvic girdle dysfunction refers to musculoskeletal disorders affecting pelvis. It primarily affects sacroiliac joint, symphysis pubis, and the associated ligaments and muscles. It is a pain in pelvic area which can present anteriorly or posteriorly. It is quite a disabling condition and affects daily functions and quality of life. Transitional activities also becomes quite difficult. It is a pregnancy pain which causes discomfort, limitation of mobility and function. So how frequently do we see pelvic girdle dysfunction in low back pain? So SI joint contributes up to 10 to 30% of all low back pains. And in pregnant women, it is quite high. And in early stages of pregnancy, it can be up to 33 to 50%, up to first 20 weeks of gestation. And as the pregnancy progresses, it can go up to 60 to 70%. And 20% of population will report severe symptoms during 20 to 30 weeks of pregnancy. So we will be mainly dealing with PSIS, iliac crest, ASIS, symphysis pubis. These are the structures we will be dealing today. So let's brush up our anatomy of pelvic girdle a little bit. So the bony pelvis consists of pelvic bones, sacrum, and coccyx. So there are 4 articulations. So 2 articulations are with the sacrum and iliac bones, one on the left side and one on the right side. Then the 2 pubic bones anteriorly form symphysis pubis, and the articulation between the sacrum and coccyx is called sacrococcygeal joint. So what are these joints? What kind of joints these are? Symphysis pubis is amphiarthroidal joint. It have a fibrocartilage. It does not have synovium in it. Sacroiliac joint is a diarthroidal joint. It has a synovium and has a fibrous capsule, and a little bit mobility is allowed. And sacrococcygeal joint is present at the apex of sacrum and coccyx, and it is amphiarthroidal joint, and occasionally there is some synovium is present. So let's look at the ligaments. Ligaments play a very important function in the stability of this pelvic girdle. So ligaments are categorized in 5 different groups. The first category is iliolumbar ligament. So this ligament is between transverse process of L5, and attachment is from L5 transverse process, and another attachment is on the iliac crest, and it provides lumbosacral stability. Then the second is ischiosacral ligaments. These are sacrotuberous and sacrospinous. These ligaments have attachment from the sacrum and to the ischium. Sacroiliac ligaments, they are divided into 4 different types depending on the flow of their fibers. The anterior, superior, inferior, and vertical, sacrococcygeal ligaments, and inguinal ligament. So as we know, SI joint is a very stable joint, and there is barely 2 to 4 degrees of mobility in this. And the movements are mainly in the form of deformations or gliding motions. And there are 3 features which provide stability to SI joint: form closure, force closure, and motor control. The form closure which suggests is because of the shape of this joint. It provides vertical support of the load, and a firm closure is provided by the passive forces, which is given by the shape of the bones, capsule, and ligament. Force closure, as the name suggests, is because of the dynamic forces of muscles. It provides horizontal support of the load directed internally, and the muscles are arranged in a crisscross manner to brace and provide the stability. Motor control, it is the coordination between the nervous system and the muscles that stabilize the lower back and the pelvic area. So there are two different groups of muscles which provide stability, primary muscles and the secondary muscles. All these muscles cover the pelvic girdle from all the sides, lower and upper side. So we will start from anterior. The muscles in the anterior are our abdominal muscles, mainly transverse abdominis and rectus abdominis. Posteriorly, our back muscles, quadratus lumborum, multifidus, and erector spinae. At the bottom is pelvic floor muscles, and at the top, diaphragm. The secondary muscles are the muscles which have attachment above and below the SI joint, and they are called slings. And there are 4 different slings: lateral sling, deep posterior longitudinal sling, posterior oblique sling, anterior oblique sling. For example, lateral sling consists of the left latissimus dorsi and the right gluteus muscle, right gluteus maximus, which gives stability to the right SI joint. So all these muscular slings help stabilize the SI joint. Stabilizing muscles of the symphysis pubis are rectus abdominis, transverse abdominis, inferior obliques, and adductor longus from the adductor group. Now supply to the SI joint. SI joint is very well innervated. It receives innervation from the ventral rami of L4, L5, superior gluteal nerve, and dorsal rami of L5, S1. Different individuals have varied innervation of SI joint, and that is the reason the patient coming back with pelvic girdle dysfunction will show us different symptoms. Now supplied to the pubic symphysis, supplied by the branches of pudendal nerves, genitofemoral, and or ilioinguinal nerves. So what are the functions of pelvis? As we know, it's a strong and rigid bony structure, and it performs number of roles. So transfer of weight. So all the weight from our head, thorax, abdomen, upper extremities, pelvic viscera is transferred down to the lower extremities. It provides attachment for the number of muscles for the movement and the locomotion. Then contains and protects the abdominopelvic viscera. Let's look at the biomechanics, sacral mutation. So what is sacral mutation? So when the sacrum moves forward and rotates anteriorly, and the coccyx moves posteriorly, then it is in relation to the iliac bones, then it is said that the sacrum is nutated. When the sacrum is in nutated position, the efficiency of load transfers increase. Nutation happens in anticipation of load transfer, standing, walking, flexion, and extension. And amplitude of the sacral nutation is controlled by sacral multifidus and pelvic floor muscles, and it is restricted by sacrotuberous ligament and biceps femoris. Counter nutation. Counter nutation is when the sacrum, nutated sacrum, when it goes back to its neutral state or the original state, the sacrum rotates posteriorly in relation to the iliac bones, and the coccyx rotates anteriorly. Then it is said that the sacrum is counter nutated. It happens in supine position, and the movement is limited by long dorsal sacroiliac ligament and by the co-activation of latissimus dorsi. So let's look at the causes of pelvic girdle dysfunction. Trauma, it could be high impact trauma such as motor vehicular accidents, Lax ligaments during pregnancy. As we know that during pregnancy, relaxin hormone is secreted, which makes all the ligaments soft, stretchy, and lax, and they are unable to provide stability to the pelvic girdle. Another factor during pregnancy is that there are change in biomechanics, change in posture, change in weight bearing and walking pattern. Increased weight can stress pelvic girdle, causing pain. Mechanical stress, a simple mechanical stress like tripping on something or stepping on in a hole or getting pulled in on one side when you are unaware can cause stress on this joint. Osteoarthritis, sports injuries, high impact sports injuries can hurt pelvic girdle, and leg length discrepancy. When there is a leg length discrepancy, the weight transfer does not happen properly, and which can strain the pelvic girdle. So how does it interfere with daily activities? Any transitional movement can cause a lot of discomfort. So when you change the movement, when you change the position, there is change in weight transfer. So as like simple activity as rolling in bed can strain this joint and cause a lot of pain. So I have listed all the transitional activities which can strain, like rolling, getting up in the bed, sit to stand, walking, climbing, standing on one leg can hurt this area a lot. So how do the patient come to us with pelvic girdle dysfunction? So SI joint dysfunction is a result of impaired load transfer through SI joints. Pain at the 14th area. I will explain what the 14th area is in the next slide. Gluteal fold pain, radicular pain, it can radiate to the posterior thigh and up to the knee mainly, and sometimes it can radiate below the knee. So this gluteal fold pain and radicular pain can imitate the pain coming from low back. Pelvic girdle pain can be on the anterior side. It can radiate to groin, lower abdomen, perineal area, and sometimes it can stay at the symphysis pubis. So what is 14th area? So area around SI joint, 10 centimeter caudal and 3 centimeter lateral is considered as a 14th area. And what is 14th finger test? When the patient points to this area twice, identifying it as a area of pain, then it is called the 14th finger test. And it is said to be positive if patient shows it twice. And then comes the special test. These tests are done in a static position. We can evaluate a patient in standing or in supine position. In this, we are looking for the tenderness and symmetry of ASIS, iliac crest, PSIS, and symphysis pubis. Dynamic test, there are a lot of different tests in literature. I am not going to go in detail about these tests, but there is a current recommendation of cluster of Laslet. So in cluster of Laslet, 3 tests were initially recommended, and then it has been reduced down to the 4 tests because the other 2 tests does not provide any diagnostic value. So what is distraction test? In this, the patient is lying supine, and the therapist stand on the symptomatic side. Therapist places both hands on the ASIS with the elbow straight, and therapist bending forward. The downward posterior and lateral thrust are given. 3 to 6 medium velocity thrust are given. In all this test, we are looking for provocation of patient's original pain. If the first test or the first thrust itself produces the pain, we don't need to go to the third or up to the 6th thrust. Then comes the thigh thrust. In this, the patient is on the are you guys having difficulty? Let me put the laser pointer. So this is the thigh thrust test. In this, the therapist is on the patient's asymptomatic side, and the patient's hip is flexed at 90 degrees. Therapist puts one hand under the sacrum, other hand curls the knee. And in this, downward longitudinal thrusts are given. Again, thrust going downwards, and 3 to 6 medium velocity thrusts are given. Again, we are looking for reproduction of patient's pain. This is compression test. In this, the patient is on the side, lying on the asymptomatic side. The painful side is at the top. The hips are at 45 degrees, knees are at 90 degrees, and the therapist is standing behind. Therapist puts the hand on the iliac crest, and again, a downward thrust are given. 3 to 6 medium velocity thrust are given to reproduce the pain. Sacral thrust. In this position, the patient is in the prone position. Therapist puts the hand on S2, and the direction of the thrust is going anteriorly, and therapist gives the thrust with the elbow stretched and the force going through the shoulders. Genslein's test and Faber's test were first included, but now it has been reduced to the 4. I have put a link for the YouTube video. In this video, these tests are explained very well. There are a couple of special tests which we need to look into. This ligament posterior sacroiliac ligament and PSIS tenderness is said to be the generator of pain in SI joint. And this is a differentiating thing between low back pain and SI joint pain. Asymmetrical hip rotation also signifies and differentiates between low back pain and sacroiliac joint pain. In low back pain, you will see there is equal rotation on the both sides, and the lateral rotation is a little bit more compared to the internal rotation in the low back pain. In sacroiliac joint pain, there is asymmetrical rotation between both the hips. Symphysis pubic pain dysfunction. Again, because of the hormonal changes, ligaments become soft, stretchy, and lax, and are not able to hold the two pubic bones together, causing pain anteriorly. Active SLR is quite painful, and there is tenderness in symphysis pubis. And if you look at the symmetry, sometimes you can see that one pubic bone is little higher compared to the other. So what are the things we need to look for in the treatment? So clinical history, then location of the pain is assessed, then cluster of Lasless is done to see if it is positive, balancing exercises, home exercise program. Patient is educated about the activities which they need to modify to reduce the pain. Evaluation for sacroiliac belt, and stretching and relaxing exercises, strengthening exercise, especially is the core strengthening. So let's look at the first pelvic balancing exercise. In this, the patient is in a hook line position, and the left hip flexion is resisted, and the contralateral side hip extension is resisted. We ask the patient to push down on the bed or the plinth. Effort is for 40 to 50%, and breathing coordination is done while doing these exercises. 2 sets of 5 with 10 count hold, and checking is done with the cluster test, tenderness, and the mobility of the patient. Home program for 1 week is given with 10 repetitions, and trial for sacroiliac belt or assessment is done. Patient is asked to or taught how to do the assessment, self-assessment before the correcting exercise and after the correcting exercise. Second pelvic balancing exercise. This is quite easy and pain-free for the patient. Patient is in the hook line position, and abduction and adduction is with coordinated diaphragmatic breathing. So patient is asked to do inhalation, abduction, toe out, and relaxation of pelvic floor muscles. And it is done at the count of 5. And then the patient is asked to exhale, adduct the legs, toe in like this, and then contraction of the pelvic floor muscle is asked. And 3 sets of 10 is done. And this is quite an easy and pain-free exercise normally. Pelvic balancing exercise number 3. It is same as the second pelvic balancing exercise. In this, resistance is given for abduction with TheraBand, and for adduction, we can use a pillow or a ball. 3 sets of 10 as tolerated. Sometimes patient might not be able to do resisted abduction and adduction immediately. You have to give a few days or a week's time to do this. So if the patient is still not feeling better with these earlier pelvic balancing exercises, then we go on to the 4th pelvic balancing exercise. Sacral assessment is done. Again, a little bit clinical history, and the area of the pain is assessed. Symptoms of difficulty lying supine and rolling is the major factor in doing this balancing exercise. In this, the patient sits with the asymptomatic leg on the plinth and the other leg hanging down, and the effort is submaximal with the axial rotation, and 2 sets of 3 reps of 10 count hold. It is done, and then patient is asked to change the position with the symptomatic leg on the plinth and the other leg hanging down. In this, the patient is asked not to lean forward or backward while doing this exercise. And home program is daily 2 to 3 times per day or as needed. And after this balancing exercise is done, we look for the reduction in pain and increased mobility. We also need to evaluate patient for sacroiliac belt. So we need to do assessment. So when the patient is standing, the therapist hold the both sides of the pelvic girdle and gives little compression while the patient is walking. If there is little bit of pain relief, then the patient is eligible for sacroiliac belt. Tension in this belt is comparable to the core muscle activity. Pelvic belt reduces the sacroiliac laxity, and the positioning of the SI belt should be such that it is below the ASIS, but it should not be on the pubic symphysis. So what are the things and what modification we tell our patient to do if they are going through pelvic girdle dysfunction? So they are told not to do any activities which will aggravate the pain. No standing on one leg while putting socks, shoes, or pants. Try to stand with equal weight on both legs. While sleeping and rolling, they are asked to put a pillow between the legs, and while rolling, they are asked to squeeze their gluteal muscles so that this pain in the pelvic girdle is reduced. While sitting, we need to educate them not to cross their legs and sit squarely. Modify their sitting down and getting up. So when they are getting up, we ask them to put both hands on the knee, and their nose should be over the toes. So they bend forward and push down on their knees to stand up. So this reduces lot of weight transfer through the pelvic area. And same thing while sitting down, the patient is bent forward so that they can see their feet, hands on their knees, and slowly they need to sit down. We need to tell patient how to get in the car and get out of the car. So when the patient is getting out of the car, when they need to swing their both legs together and then turn their body facing outwards, and sit to stand is done as explained in the point 6. And while getting in the car, they need to sit first with their legs out and then swing their both legs in, and then sit in the car. Do not carry child on one hip, or do not carry bags or heavy weight on one side. Carry equally on both sides if you have to carry. Climbing up the steps, down the steps is easy on the pelvis if the patient goes sideways and comes down sideways, and taking smaller steps while walking will reduce lot of pain. So no physiotherapy treatment plan is complete without stretching and strengthening exercises. So stretching exercises we need to do for back muscles, hamstrings, and hip flexors. Strengthening exercises for mostly all the muscles in and around the pelvic girdle. Clamshell, we can do resisted clamshell with TheraBand. Sideline abduction with TheraBand can be done. Bridges to strengthen gluteal muscles, pelvic floor strengthening, adductor strengthening, back extensor strengthening can be done when the patient is on all fours, hands and knees, and lifting opposite leg and hand. Then in standing air squats can also build up the muscles around the pelvic area. So let's summarize all the points what we have looked at. Clinical history and the location of pain is assessed. Tenderness and symmetry of bony prominences is evaluated. 14th sign is assessed. Laslet's cluster test is seen. Balancing exercises. Teaching patients to do self-evaluation before and after balancing exercises. Evaluation for sacroiliac belt is done if it is needed. Stretching and strengthening exercises are given to strengthen the muscles around the pelvic floor. And I would like to conclude my presentation. I would like to thank each and every listener for attending this seminar and being very good and patient listener. Again, I would like to thank Dr. Hannah Rajshekhar, Dr. Himani Poddar, and Dr. Manjula for having me and giving me this opportunity to conduct this webinar. And if there are any questions, we will go with that.
Thank you, Dr. Vaibhavi. It was an amazing webinar. It was very informative. Waiting for the questions and then we'll conclude. We have this question. Yes, we have this one question: how to assess pelvic girdle dysfunction in immediate postpartum, post C-section?
We have to, the patient will not be able to tolerate all those cluster of Laslet's tests. Even most of the time, I am not able to do it on my pregnant patients. So looking for the tenderness and the symmetry, we can go for the balancing exercises, and patient will get benefit. I have seen patients who are in ICU and just with simple balancing exercise, whatever they can tolerate, they have found relief.
Okay, thank you. So, Dr. Vaibhavi, women with pelvic girdle pain can be treated at any stage of pregnancy?
Yes,
Right?
yes. The pain is more severe in the later part of the pregnancy because of the weight and the change in dynamics. But yes, we can treat at any time. Yeah, that's what we will not be able to do this all cluster of laslets, these tests. I am barely able to do this test because the patients are pregnant and they come to me with severe pain. So I also mainly go with the 14 signs, the pattern of pain which I see. I go by their walking pattern and the history which they gave me. And of course, we look for the tenderness and symmetry. And on that basis, mainly I am able to give the treatment and we can get good results.
Okay, thank you. So the other question is, can you please explain 14th finger test?
Yeah, so the 14th, let me go to the slide.
Yeah.
So the area around SI joint, 10 centimeter inferior or caudal to this area and 3 centimeters lateral to this area is called 14th area. And patient comes and tells that, oh, I'm having pain in this area. So if the patient points out to this area twice, then the 14th finger test is said to be positive.
Okay. So we'll wait for a few more questions. During ANC period, how to differentiate? Yeah, just a minute, this question. It's deleted. Yeah, the question is during ANC period, how to differentiate between previous scar, dehiscence pain, and pelvic girdle pain?
Can you repeat? Differentiate between low back pain or something else?
Differentiate between previous scar, dehiscence pain, and pelvic girdle pain.
This pelvic girdle pain is very typical.
Okay.
I don't know what are the symptoms of the Hansen's scar.
Okay.
But in the pelvic girdle pain, all the transitional movements become painful. So once the patient achieves the posture, the patient is fine. But if the patient is trying to sit or stand or walk a little bit, or while getting up from the bed where there is a change in load transfer, the pain gets aggravated.
Okay. So we have one more question, how to differentiate between pubic symphysitis and pelvic girdle pain specifically?
In the literature, it is it is used synonymously, sacroiliitis or sacroiliac dysfunction. So, it could be on the similar treatment, but if there is symphysis pubicitis, then the patient will need rest and maybe pain medication or medication to decrease the inflammation.
Okay, thank you. Thank you, ma'am. So yes, we don't have any more questions. So to conclude this pelvic girdle dysfunction, I must say that Physiotherapy helps women by improving spinal and pelvic girdle biomechanics and stability, improving strength of the trunk and pelvic girdle muscle, improving hip mobility, controlling pain, and improving function. Am I right, Dr. Vaibhavi?
Yes.
Yeah, thank you. So, yeah. Over to you, Hannah ma'am.
Dr. Vaibhavi, your session was very nice. You have covered all the aspects of good, clinical reasoning, where anybody can, when you see the patient, you'll be able to assess properly as well as treat. Very well explained in a simple, short time. It was very informative, and thanks a lot.
Thank you.
Thank you, Dr. Vaibhavi.
Thank you.
So, yeah.
Thank you so very much to our respective resource person, Dr. Vaibhavi. I think we have no questions from our participants. Dr. Himani, do we have anything else scheduled, or we can wind up?
Yeah, we can wind up. I have asked all the questions which were on the YouTube.
Great.
And yeah.
Great. Thank you so much. So thank you all the participants.
Thanks a lot, Dr. Sushant, for coordinating, and the other people on the platform who made this possible for us.
Thank you, ma'am.
Thanks a lot for doing the needful.
My pleasure, ma'am.
Thank you
very much. I request all the participants to kindly subscribe to YouTube channel of IAP India and also IAP Facebook page, and so that they can be updated about our further and future webinars and sessions. And thank you so much to all our panelists. And thank you, Dr. Himani, for wonderfully moderating the session.
Thank you, Dr. Suman.
Thank you.